Oh my God.
When your community needs you most. That's something my next guests fully appreciate. A few weeks ago, they
Hi, everyone. We'll get started in probably another minute or so. Just give a few more people time to get in here. All right. Well, welcome everyone. It's 7 o'clock, so we'll go ahead and get started. I'm sure we'll have a few more people who join us. Can you see my slides? All right. Someone give me a thumbs up or yeah. All right, great. Thank you. My name's Kelly Macauley, and I'm one of the instructors for Therapy Ed, and I'll be leading our discussion today about, we're just going to be reviewing the physical therapy clinical practice guideline for the management of people with heart failure. So we'll do a little bit of a pathophys review and then sort of walk through the decision making in the clinical practice guideline. And then we will circle back to and answer just a couple of questions. Before we get started, it's always great to get an idea of when people are taking the exam. So can you go ahead and just throw that in the chat when you'll be sitting for the exam? However, it looks like a lot of Julys. Okay, there's a couple of October. Ooh, August in Canada. Fantastic. All right, great. So it looks like mostly July, but we've got some Octobers in there, and Welcome to our Canadian friends. Thanks for joining us. All right. So, and good for you folks who are taking in October to get an early start here. This is a great opportunity for you to hear several different presentations and sort of get the ball rolling for you. So good for you. It's always better to plan ahead so you're not scrambling at the last minute. I think we're starting to get everybody in here. All right. So just a little bit about myself. I am currently a clinical professor and I work in the hybrid DPT program at Northern Arizona University. I almost went for longest commute because I actually live in Scarborough, Maine. I obviously went to PT school, and then I also have a doctorate in educational leadership with a specialization in educational technology. I'm a board certified clinical specialist in both cardiovascular and pulmonary PT, as well as geriatric PT. And I really enjoy doing these talks we always get great questions and a great discussion. So why are we talking about the cardiopulmonary system? Well, as you probably know already, it takes up about 13% of the NPTE exam. So you'll have about 7 to 9 questions are on the examination, 7 to 9 questions are on the foundations, the eval and differential diagnoses, and then you have 8 to 10 on interventions. And we're actually gonna hit on all 3 of these sections pertaining to heart failure today. So it should give you a nice holistic background to help you in your preparation. If you have questions as we're going on, don't hesitate to stop me. Just go ahead and throw them right in the chat there, and I'll be monitoring that as we go through. So the 3 things we're really going to address is looking and reviewing that pathophysiology of heart failure. We're going to discuss the heart failure clinical practice guidelines, and then we're going to talk about just a couple of questions related to heart failure that are similar to the NPTE questions that you guys will see in July or October. To get us started, I'm going to have you all put
But you cannot watch
a risk
iPad
factor for cardiovascular disease.
Here ولا هوني no iPad.
All right, let's see what we got here. I see hypertension, great. Obesity, great. Diabetes, great. Lifestyle, yeah, that encompasses a lot of things there. Hypertension, a sedentary lifestyle. Yeah, unfortunately, age. They say a lot of things get better with age, but cardiovascular disease gets a little worse, unfortunately. Smoking, lifestyle smoking, good. Yeah. Hereditary. Yeah. Bad genes can really lead to cardiovascular disease. Alcohol, great inclusion there as well. Drugs and alcohol really are not favorable for cardiovascular disease either. So you guys did a great job there. I'm trying to think of the only other ones. You said hereditary. Great job. You guys got my entire list there. The only other one that I think I have is like dyslipidemia or high cholesterol. But otherwise, you guys nailed it. All of those things put you at increased risk for developing cardiovascular disease. Yeah, we're okay. And why is that important? Well, that actually starts the process of heart failure. It starts with those risk factors. And like I think somebody said, almost everything that y'all mentioned, except for obviously hereditary and like family history and age, most of those things are actually modifiable, which is important to remember. However, we're going to talk about people who haven't modified these. So you have all these risk factors, and then it puts you at risk for vascular dysfunction. Unfortunately, even within your first decade of life, oh yeah, stress is another risk factor, absolutely. In your first decade of life, you actually end up starting the atherosclerosis process. It starts really early, but all of those risk factors can make it accelerate that process. And something like smoking or diabetes actually accelerates it fourfold. And so that ultimately leads to vascular dysfunction. If we live forever, we would eventually develop that, even if we did everything right. But those risk factors, again, accelerate that process. And what happens when you have that vascular dysfunction, you have that laying down of plaque and other things essentially on the inside of your vessels, and it leads to decrease in flow. And that leads to that vascular disease that we end up with. And you can end up with a couple of different types of tissue injury. And I've listed here the two most common ways that we end up with tissue injury that lead to heart failure. Oh, excuse me. Excuse me. The first way I'm going to talk about is an MI. So you have that vascular disease and you end up with decreased blood flow to a particular area of the heart. Usually it's the myocardium, but and usually the left side of the heart, but it can be other areas as well. That's the area that has the highest demand. So you end up with an acute infarction somewhere, and you can see this is sort of on the inferior part of the ventricle. When you have that area of acute infarction, it's really important that in the immediate time frame to let it heal. It's like any other soft tissue injury. If you let it go ahead and heal, it can really reduce the number or the extent of the injury, because you have this area that's the area of infarct, and then you have an area that's a zone of ischemia around it. And if we let that part heal and let the blood flow get restored to that area, it can really help to promote healing and decrease the extent of the injury. So that's in the acute phase. But here we're talking about sort of that post-MI remodeling period after that. So you'll have this area that was the acute infarct that once it's dead, it's dead. There's nothing we can do about it. And over time, what happens is you get this thinning of the myocardium, and it actually causes the ventricle to elongate a little bit. And this causes a different type of shape for your ventricle. Your ventricle is very picky. It doesn't like to have, and it's got very specific mechanics, and it doesn't like to be misshapen at all. And if it does, it ends up creating an abnormal contraction pattern. And that's partially due to the scar that's formed here, because think about if you have a scar, that's no longer going to be contractile. And it also eventually leads to this hypertrophy because it has to work harder because of the different shape. And this hypertrophy is also not a normal hypertrophy. It's a hypertrophy that's got a lot of interstitial collagen in it. And so again, that makes collagen is not a contractile tissue. So that makes it so it's not contracting normally. So all of this is causing the ventricle to not contract and work in its normal way. And this sort of remodeling process happens over time. Ooh, here we go. And that's what we're talking about here, this pathologic remodeling. It eventually, with someone with an MI over time, and depending upon the size of MI and all other factors, will lead to organ dysfunction. And that's what I mean when it's not contracting normally. So every time, maybe your ejection fraction is just a little bit less. So the amount of blood leaving that ventricle is just a skosh smaller every time. And that can lead to dilation of the ventricle, and it can eventually lead to organ failure. There's another process that I want to sort of talk through that is one of the more common ways that we end up with heart failure, and that's if you have chronic hypertension. So we have a good question in the chat. How long does this usually take, the pathologic remodeling? And of course, you guys are probably used to this answer. It depends. It depends upon the size of the MI. So if we have this picture here where maybe it's a smaller MI, it could be years and years and years before we actually see sort of any sort of pathology. If it's a large MI where maybe it took out like half the myocardium, then that's something that where we would see abnormalities a lot sooner. But I mean, if it's, and the other component is, does the person have they had other events? So there's other pathology. Do they have something from a hereditary standpoint? Maybe they already have an underlying cardiomyopathy because they have a genetic issue that led to that. So all of those sort of would speed up the process, and we'd see this pathologic remodeling happen a lot sooner. So it depends. It can take several years, or maybe if there was a lot of, I would say the perfect storm, and maybe it's only a couple of months before we see that happen. All right. So the other thing that can happen with this, we have that myocardial dysfunction. And that myocardial dysfunction, if it doesn't happen because of an MI, it can happen if someone has chronic hypertension and it's not treated. So the myocardium is working really hard all the time. And the myocardium is a muscle like any of your other muscles. If it always has resistance to it and it has to work hard, which is what happens when you have hypertension, it means the ventricle has to work hard to push the blood out against the afterload or the pressure, like that's on the other side of the aortic valve. That muscle is going to hypertrophy, and that can lead to dysfunction. And if you have that sort of hypertrophy, it can lead to decreased stroke volume. So you have decreased blood being injected every time. And then if that happens, then the ventricle starts to fill with blood over time. So say, I'm going to make up numbers here just to make it easy, but let's say you would normally eject out 100 cc's every time you have a normal stroke volume. But let's say now you're only ejecting out 90 cc's. So every time your heart contracts, you've got 10 cc's that are left in your ventricle. So that over time is going to increase that volume. And we call that the diastolic volume because that's the volume that's in there when the heart's at rest. And that's going to increase the pressure. This leads to more remodeling because now we have an increased stiffness because it keeps hypertrophying. You know, think about big bodybuilders who have really, really hypertrophied muscles. They're not known to be really limber, right? They're known to be pretty stiff. Same thing's happening to your myocardium. And the other issue with that stiffness is, remember that the filling process into the ventricle from the atrium tends to be a passive process, except for the last 20% where you have your atrial kick. So it relies on the ventricle to have elasticity in it. And if it becomes really stiff and it doesn't have that elasticity, it's going to make it harder to fill. So that's a problem. And then because of that, that leads to more myocardial dysfunction. The other issue with this remodeling is it leads to increased myocardial oxygen demand. If you have high blood pressure and the heart has to pump harder to overcome the pressures, it needs more oxygen to do that. The myocardium needs that oxygen to meet the demand of the activity. So that's a whole way this can lead to more myocardial dysfunction. When you have this decreased stroke volume, and so you have, blood that's sticking around in the ventricle, the renin-angiotensin-aldosterone system is activated. And what this does is it causes your body to hold on to sodium and water. Now, this initially, it's a really good idea for your body because essentially what it does is it sort of increases the stretch to the myocardium to try to make put it in a different length tension relationship so it is a more efficient contraction. And initially, it works really well because you get the position of the sarcomeres and everything in a slightly different position, and it allows for a nice contraction. Unfortunately, it also continues to increase the circulating blood volume. So over time, it gets to the point where you're ventricle becomes so stretched that the activation of this system is actually essentially harmful to the body. And that causes more remodeling process. And if we just scoot back here for a second, so we have another type of pathological remodeling that can lead to organ dysfunction. And again, ultimately, that whole system will lead to organ failure. So those are just a couple of ways, using MI and hypertension as an example, that we can end up with organ failure. And those are probably the two most common ways that we'll see. There's certainly oodles of other ways, but the same process essentially happens. You end up with some sort of injury, you end up with some hypertrophy in the muscle, you end up with some abnormal movement of the muscle that leads to more hypertrophy, and eventually the organ's not functioning as it normally should, and eventually that process just really keeps snowballing to the point where you have organ failure. The kidneys do eventually start to fail with the heart. Similar to your last question, Patrick, it depends upon the person at what point the kidneys fail. If the pathologic process that the person has is related to hypertension, the kidneys are really susceptible to chronic hypertension, and you can get a lot of kidney damage from that. And you usually see the kidneys and the heart fail at the same time in that case. If the organ damage is more from something like an MI, and you don't have that sort of chronic process that's taxing the kidneys, then the heart may fail before the kidneys. But it's not uncommon that the kidneys catch up pretty quickly because of the chronic stress on the body. Also, a lot of the medications that we use to treat heart failure are really tough on the kidneys. So that can lead to some issues as well. But it's very common that they do fail together, again, depending upon the pathologic process that caused the cardiac dysfunction. So I want to turn our attention now to the CPG that came out a couple of years ago, and it really does a nice job categorizing patients with heart failure and helping create sort of an algorithm for when we should treat them and when we shouldn't. So we're getting back to that sort of differential diagnosis part and examination part, that questions you may see on the boards. But then they did a really nice job taking the evidence and with treatment recommendations for folks with heart failure. So let's go through the different parts of it. The first thing that I want to call your attention to is the classifications of heart failure. And this may look familiar to you. The first system that came out was the NYHA, which is the New York Heart Association classes of heart failure. And it goes from 1 to 4 in Roman numerals, where 1 means you have absolutely no limitation, and 4 means you have symptoms at rest and you're really not able to do any activity because of your symptoms. And then 2 is some slight limitations. You're comfortable at rest, but when you do activity, you have some problems. And then New York Heart Association class 3 is you have marked limitation in physical activity, but you're comfortable at rest still, but less so when you do ordinary activities. So it's this progression. The problem with the New York Heart Association class, and the reason the AHA, ACC stages that's pictured here on the left were developed, is because the New York Heart Association classes are based solely on symptoms. So if someone comes into the hospital, they might be classified as class 4. They have symptoms at rest, they're unable to do any sort of physical activity because they're so overloaded. But let's say we put them on Lasix, we give them some IV Lasix. A couple hours later, even, it could be that quick, they've already dropped. And maybe now they're only a 3 or a 2. Or if we come back the next day, maybe they're a 2, because they've had this medication management. So it did a good job of classifying how the person felt in the moment, but it didn't really capture the underlying structural disease process that exists. So that's why the AHA and the ACC created the stages of heart failure. So stage A is someone who's at risk for developing heart failure, but they've never had any signs of it. So all those risk factors that y'all pointed out at the beginning, maybe they have some of those risk factors, but they certainly don't have any disease. Or maybe they've had an MI, but they don't have, again, any signs, symptoms, or anything like that of heart failure. Actually, the MI is not a good example of stage A because that would be a structural or functional abnormality. It's a good example for stage B. It's a structure where you have structural heart disease that is strongly associated with the development of heart failure, but no signs and symptoms of heart failure. So that's an MI. So potentially, maybe this person had an MI. So they have structural disease, but they don't have any signs and symptoms of heart failure yet. Stage C is where they actually have symptomatic heart failure and they have underlying heart disease. Stage D is when you have advanced structural disease with marked symptomatology at rest despite maximal medical therapy. Good question, Maddie. Do we need to know all these specifics for the NPTE? I would have an idea of the two different classification systems and generally that they're getting worse from A to Z and 1 to 4, and that the New York Heart Association classes are based on symptoms and the stages are based on underlying structural disease. If you know those things, I think it would put you in good shape to answer any questions, even if it was more specific. So this picture does a nice job of showing the overlap, but as you can see, the New York Heart Association classes can all be in stage C of the AHA, ACC. So there's a lot of variability, but I think what you'll find used more is the AHA, ACC stages. I said that, Shannon, and I misspoke because an acute MI would be structural disease of the heart. In stage A, you don't have any structural or functional abnormality. So I would argue that an acute MI would actually be stage B because you have structural disease of the heart at that point, if they've had an MI. Because if you have an MI, you've had an infarction, which is structural disease. All right, so that is the classification system here. Let's talk now about when would we treat someone. And this is a busy little chart, but let's walk through it because it can be quite helpful. So what they do, obviously you can see it's kind of the stoplight version of should we treat this person or not? This really helps us to make clinical decisions based on the signs and symptoms that the patient has. So in the green zone, we have patients who don't have they have a history of heart failure, but currently they have no shortness of breath, swelling, weight gain, chest pain, or decrease in the ability to maintain an activity level. Therefore, this is someone we can treat, no problem. They just have that history of heart failure, but they don't have active or decompensated heart failure right now. So there's no problem with treating them. Let's talk about the yellow zone. So this is someone who in the past 2 to 24 hours, they've had maybe a 2 to 3 pound weight gain. They have a little bit of a cough maybe. And for folks with heart failure, it's kind of a dry cough that they have. It's not, something like that would have any secretions with it usually. They might have peripheral edema. They might have some shortness of breath or orthopnea, which is that inability to lie flat because of shortness of breath. So these symptoms may indicate that their medication needs to be modified. It means that we probably want to talk to their physician about their medications, and just to give them a heads up, they're in this yellow zone. It doesn't mean we can't treat them, but we're going to be limited by their symptoms. But we should definitely be having a conversation with their medical team to give them a heads up that it looks like things are getting a little bit worse here. The red zone is when they have shortness of breath at rest, they have chest pain, wheezing, or chest tightness at rest. They have paroxysmal nocturnal dyspnea, so they just have this acute shortness of breath in the evening. They have a weight gain of at least 5 pounds in 3 days. They have confusion. All of these are overt signs of decompensated heart failure. And this is someone who needs to get to an emergency room or their physician's office and pretty quickly to be medically managed. Yeah, Patrick.
Yes, just a quick question. So if we have somebody that has gained 5 pounds in 3 days, wouldn't that be classified already as a congestive heart failure?
It should be, but they may not know that. This may be someone coming into like an outpatient appointment. Maybe that you were treating them because they had a total knee and they come in with these symptoms. So I want
Okay.
you to be able to recognize, well, this is someone in, like you're saying, who's in heart failure. They need to be treated by a physician.
Okay, perfect. Thanks.
Yeah. Yeah. Hopefully if they were in a hospital setting or something like that, someone would have been treating them already. Like if that's why they went to the hospital, then yeah, of course, you're absolutely right. But this is for people that potentially you're seeing an outpatient. Maybe you're seeing in home care. Maybe you've been seeing them for a couple of weeks and all of a sudden they have these symptoms. So it's being able to recognize those signs and symptoms.
Okay, perfect. Thanks.
Elijah, with stable angina, would they be classified in the yellow zone? I would classify them in the yellow zone. If all they have is stable angina, yeah, for sure. I'm actually waffling if I would even say green zone. I would put them in the yellow zone probably just because you want to make sure you're staying below that point where you induce the angina. So it's someone that you can certainly treat, but obviously with some caution. All right. Good questions. So we have our green light, our yellow light, and our red light on whether we can treat these folks or not. All right, hang on. This next slide is a little bit messy, but we'll walk through it. It really is layering on the patient's symptoms that we just talked about, which are in these square boxes, and then adding on the results of the physical exam and how does the physical exam change our decision making. So we'll start at the top. We have a patient here with heart failure, and then we want to think about, are they in the red, green, or yellow zones? So this first one is we were starting in the green zone, and now let's do some physical exam. Let's take a listen to their breath sounds. Do we hear crackles? Let's listen to their heart. Do we hear an S3? And then let's look, do they have jugular vein distension? That's what that JVD is. If the answer to these is yes, even though they were in the green zone, then it's starting to show that they may have some signs and symptoms. It would probably be, it's not something that's going to happen very often if they didn't have any of these signs, but if they did, it may be someone that you want to talk to their physician. They may need some modification of their medications. It doesn't mean you can't treat them again, but you probably, if they have some of these physical exam findings, you want to make sure they're getting medically maximized before they get worse. If they don't, then there's no reason you can't treat them. And we'll look at another algorithm in a second to look at what we can do. If you've identified this middle column here is that yellow zone. If you've identified that they're in that yellow zone, now go ahead and do the physical exam. Those three things: listen to their breath sounds, listen to their heart sounds, and then just look at their jugular vein. Do they have all three of these findings? Then if the answer is yes, they really need to be treated medically before we see them. If they don't, then we can proceed with what we had said before. They're in that yellow zone. We want to have a conversation with their physician. They are getting a little bit worse, but they're still maybe able to tolerate some activity. If they have those findings, then no. This is something that they either need to go to the ED or, at least go to their physician's office. And that's the same as if they had these red zone findings. We would send them right there to their physician's office or the ED. So this takes this initial sort of screening, red, green, and yellow zone, and adds on some physical exam findings. those physical exam findings give us a really nice picture, and especially when we're communicating with physicians, it can be really helpful to have that information. So it helps them to make decisions about how they may change their medical management. All right. So let's say that this person was either in the green zone or the yellow zone. And where would we start with treating them? Well, we have a lot of options. Here's another complicated algorithm, but we're going to walk through it together. So you have a patient with heart failure, and we want to look for signs of decompensation. And that's what we just did. If they were in that red zone, they need to be medically managed. It's too early for physical therapy. If they're in the yellow zone and you decide you think that they should be seen by their physician first, and they need medical management, then it's too early. If you talk to their physician and they have medical management and it's okay, then you may decide that you don't, or you still could treat them. If you look and they're in the green zone, you want to start to think about at the ICF level now, do they have limitations like participation restrictions? Is there things that they can't do? If the answer is no and they're physically active, then you don't necessarily need to treat them. If the answer is yes, and they have activity limitations, then there may be activities that we can help them perform. So interventions like gait, balance, aerobic conditioning, all of those things. Is there an endurance limitation? If the answer is yes, then you want to see, can it be relieved by rest? And if they have signs of exertional intolerance, then if the answer is yes and it can't be relieved by rest, then that's an emergency medical problem. If they have signs of exertional intolerance, they don't have signs of exertional intolerance, then there's a whole bunch of interventions that we can do. So generally speaking, to sort of step back and summarize, if you have a patient with heart failure and they don't have signs of decompensation, so we put them in that green zone, then you want to figure out, do they have participation restrictions? Are there things that they're limited in? If the answer is no and they're physically active, then we don't necessarily need to treat them. In most cases, though, they will have participation restrictions or activity limitations, and we want to go ahead and foster a sort of a culture where they are mobilizing and getting stronger and doing a strengthening routine and all of those things. Okay. Let's talk through a few of the specific interventions that have some really nice literature to support them. So the first one is really just advocating for increased total daily activity. And this has really strong evidence for it. And this is the type of thing where you think about, parking a little bit further away from the grocery store, so you have to walk a little bit further. Maybe it's doing things around the house, cleaning and stuff like that, where you're just being generally more active throughout your day. You're not really doing any specific exercise, but just being more active. So that's something that we want to stress with almost all of our patients anyway, but particularly those with heart failure, because the more reserve and activity tolerance that they have, the better off they'll be in the long run. Something else that's really helpful that we can do is to educate on chronic disease management behaviors. One of those things has to do with activity. Some of those other things are certainly making sure they're doing their daily assessments so that because the goal is to keep these patients out of the hospital. And if we have good outpatient management as a holistic member of the healthcare team, this can be achieved. So it's looking at things like, are they weighing themselves daily? Do they understand the signs and symptoms of a heart failure exacerbation? Do they have good nutrition? So are they eating regularly? And then are they sticking to specific recommendations from a dietitian or a nutritionist, like low sodium diet and that type of thing? And are they consistent with their medical management? A lot of times with patients with heart failure, they might be on a diuretic, and because they have issues getting to the bathroom quickly, they may not be taking it regularly. So things like that. Are they consistent and compliant with their regimen? And then making sure that the medications they're taking are the ones they're supposed to be taking, and doing that reconciliation process. So really going through that sort of holistic management with the patient to make sure they understand the best way to manage their disease. And then we know that prescribing an exercise training program for these patients is super important. And we can, like for all classes, it's beneficial, especially for those in classes 2 and 3, or, in that B and C range, it can be really beneficial. What we want to have them do is exercise 3 to 5 times a week, anywhere from 20 to 60 minutes, depending upon what their activity tolerance is, and doing something that they like to do. And we have here 50 to 90% of peak VO2. So again, that's around, your 60, 65 to 80, 85% of your heart rate max. So right in that good moderate exercise aerobic training mode. And they can do whatever they like. It can be walking, it could be riding a bike, if they like to dance, whatever it is. Just something where they're keeping up that intensity for at least 20 minutes. Some literature shows that even 10 minutes every day can be beneficial. Heart failure with a reduced ejection fraction is HFrEF. The other, you can have heart failure with normal ejection fraction. Recently, I say recently, it was in the last 5 to 10 years, they sort of changed the name. Heart failure with reduced ejection fraction is synonymous with the old systolic heart failure, and with a preserved ejection fraction, it's what they used to think of as diastolic heart failure. They're sort of, those are the old terms. The reduced and preserved EF probably better describe the type of heart failure than systolic and diastolic did. All right, so we want to promote a culture of activity. We want to educate on how to manage their disease. We want to get them doing at least some sort of aerobic conditioning program. But we can do better than that even. We have some really strong evidence that shows for aerobic conditioning, if we do high intensity interval training, we can see great benefits. Someone asked earlier about angina. We certainly want to stay below that maximal level and below any sort of anginal threshold. But if you're doing interval training, 1 minute on, 1 minute off, or 1 minute, maybe like think for walking, maybe you're going at 4 miles an hour, and then maybe you're doing 1 minute at 2 miles an hour. That type of interval training is really beneficial in this patient population, especially when they're if they're really deconditioned and weak. Another thing that's really beneficial for folks with heart failure is a resisted exercise program for both upper and lower extremities. Part of the reason is resisted exercise training reduces the overall work of any sort of activity. So if someone has got reduced activity tolerance, if we can reduce that workload for them, then it's really beneficial. The other benefit of peripheral strength training is it increases the ability of the peripheral muscles to extract oxygen from the blood. So again, it makes those muscles more efficient and have a higher ability to use oxygen. So in patients with heart failure that may have extensive central problems with their heart that will never reverse, these peripheral changes we've seen great gains in function and even increases in aerobic capacity without changing things centrally that much. That brings me to the last one, at least on this slide, where we're talking about prescribing a combination of aerobic conditioning and resistive training. And this is where we get the biggest bang for our buck. If they're doing some sort of aerobic training a couple of times a week, and then resisted training 2 to 3 times a week, that yields the best outcomes, and it helps increase the functional outcomes even better than doing either one of these alone. Here's 3 other adjunct sort of therapies to think about. One is inspiratory muscle training. We've seen some good evidence come out that folks who have heart failure have the process of heart failure causes muscle changes throughout the body. It's not quite known why or how that sort of process works, but we know proximal muscles especially become weaker. This includes your ventilatory muscles. So some of the symptoms of shortness of breath can be mediated by doing inspiratory muscle training. And we have seen increases in quality of life and functional capacity by adding inspiratory muscle training to the patient's exercise regimen. If you combine inspiratory muscle training with aerobic exercise training, you're going to get even some better results. And I would argue that your best bet is to really combine inspiratory muscle training with overall resisted training for your upper and lower bodies and core, not bodies, extremities, and your core, as well as doing an aerobic program. Having all 3 of those is really going to give the patient the best chance to maximize their function. The last thing that can be helpful for patients with heart failure is using NMES to help increase the muscle strength. As I said, there is a myopathy associated with heart failure, and the NMES can help to reverse that. And we have the parameters here that can be useful or have found to be useful for folks with heart failure. So those are the most recommended. There are 9 different statements, but it really comes down to promoting activity, really helping people to understand the disease process and how to manage it, and then their exercise prescription, doing some sort of aerobic program, and that can be continuous, or as I said, doing interval training can be beneficial, doing some sort of resisted training, adding on inspiratory muscle training. And then especially if you have someone who's not really mobile or can't participate really well in a resisted program, adding NMES can be really helpful to consider for patients with heart failure. All right, we have a little bit of time left, so I forgot to do that. We're gonna do a couple of questions here. I'm gonna let you read that while I set up the poll. Oh, hold on, let me go to a different one there. There we go. Have you go ahead and answer this. All right. Go ahead and share the results. Yeah, I see that. Yeah. So most of y'all said answer D. So that's great. So when you have someone with New York Heart Association Class 1 heart failure and they don't have any comorbidities, what would you expect to find? So the ability to lie flat without distress, like this is someone who doesn't have any symptoms at rest. There should be no reason why they can't lie flat. The reason A is not correct is we wouldn't expect them to have a productive cough. Folks with heart failure, even in decompensated heart failure, don't usually have a productive cough. If it's productive at all, it's actually like a frothy sputum. It's not spasmodic. Spasmodic is one you'd have with a very reactive airway. Number two isn't correct because this person can lie flat without any problem because they have stage 1. If it would be like probably stage C, or New York Heart Class 3, where they would have PND. And if they have no symptoms like this, it really shouldn't affect their pulse rate. So that's sort of an irrelevant sort of finding there. All right, let's try another one. It can be more consistent with left-sided heart failure, but in most cases it is. It would have to be left-sided heart failure, and then you could have both-sided heart failure, but it wouldn't just be right-sided heart failure. Does that make sense? Like if you could have biventricular failure, but not just right-sided. That's still the same one. Oh, here we go. Okay. All right. So we have most people said C, and then we have a strong contingent that said D, and then we have a couple people jumped in there for A and B. So let's talk through this one. So you have a patient who comes in, they had a total knee replacement a couple weeks ago. And they have a couple of some cardiac risk factors, and they have a history of heart failure. But now they're showing bilateral lower extremity edema, shortness of breath with minimal activity. So it's not at rest. Shortness of breath at rest is when we probably go right to number 4. They do have some crackles. So we did our physical exam. So we know they've got some crackles. They have some jugular vein distension. What should they do next? What should we do next? So this is a tough one. And I would agree that calling either, and it also depends where you are. Calling the referring physician is a completely appropriate answer. And then I think that's completely appropriate. Because they have signs of crackles during lung auscultation and JVD, this is telling us they really should be seen by a physician. I probably wouldn't call 911 unless they can't get to the hospital or get to a physician's office themselves. If they can't, and that's the only way that can happen, then I think that's a reasonable answer. I probably, because they've got these signs that are really moving towards decompensated heart failure, I probably wouldn't send an email to the referring physician. I probably wouldn't, the physical exam I would do would probably be the lung auscultation, like those 3 things. Listen to the lungs, listen to the heart, and look for the JVD. If I saw all 3 of those as being positive, and we know they have edema as well, then I probably wouldn't do any more of a physical exam because we have some pretty great data right now telling us this person's in decompensated heart failure. So I probably wouldn't go any further than that in terms of the exam. So this was a hard one. There wasn't really, there's a couple of answers here. If the person, I would definitely say this person should see a physician, like sooner rather than later, Miranda, for sure. So if they can't get there for some reason, and you will have some patients, maybe they can't drive themselves, maybe they don't have any social supports, maybe you're in an outpatient clinic in a remote area. If that's the case, then I think emergency services could be indicated. If they can get to a physician or get to an ER, if they have someone that can take them right to their physician's office or something like that, then I think that's a completely appropriate thing. But they definitely should be seen by a physician today. Does that make sense? What would be a good example for option 4? I would say if the one thing that's helping me not go directly to option 4 here is they're not short of breath at rest. That would be the thing that would really put me over the edge. They're short of breath with minimal activity, so they're still okay. They're not great, don't get me wrong. They need to be medically managed, but if they were short of breath at rest, it would tell me that there's a worse situation. I thought I saw a hand.
Yes, sorry, it was
Yeah.
me, but then somebody actually asked that question. So actually, you just responded, but just to make sure, so the one clinical finding that in this particular scenario would warrant calling the emergency service right away, it would be the shortening of breath with at rest. Is that correct?
That's what I would differentiate it as. But here's the thing. If you were seeing this patient, you're in an outpatient setting, you're in a rural area, and you're not sure, going with EMS is not a bad choice.
Okay.
Does that make sense? Like, I think that's completely reasonable.
Okay.
Emily, if they drove themselves and didn't have a person to drive them, I think EMS might be indicated. It would be like a non-emergent sort of transport, but I think that might be a better choice because we certainly wouldn't want this person in this state driving themselves to the hospital because then they're going to put themselves and other people at risk. So it sort of it depends. It makes it a little complicated. It depends a little bit on the situation, but this is one of those ones. If you're not sure and you want to err on the side of caution, I would say 4 is not an inappropriate answer. With 2 and 3, wouldn't 2 be a better choice since there's documentation? Well, the problem is I don't know when the physician's going to get the email. That's the problem. If I call that physician's office, I'm going to speak to somebody. And you may speak to a nurse, and then what usually will happen is the nurse will get in touch with a physician very quickly, and they'll get back to you pretty quickly. So I wouldn't do that. But your point about documentation is important. So I would document in your note what you did and how you proceeded. But I would definitely err on the side of talking to somebody versus it getting lost in an email chain somewhere for this particular case. All right, let's do one more. Let me relaunch. There we go. All right, let's go ahead and talk about this one. So this one, we're a little bit all over the map. And that may be because I'm not sure if y'all are familiar with sort of dosing exercise for folks for inspiratory or high intensity interval training. So let's talk through this. So there's a couple issues with one. You're at a pretty low percentage of their peak VO2. Now, with someone in heart failure, it's okay to start a little bit lower, but we're doing interval training. So we're talking about the intervals. And so for those intervals, we actually want to push them pretty hard. So this isn't optimal. It's a little on the lower side, but the thing that gets me for this one where I would not choose it is the time. It's only 5 or 10 minutes and it's only 2 or 3 times a week. So essentially you could say they're exercising 2 times a week for 5 minutes and you're not going to get any aerobic gains from that. So the intensity of this one and the time and the frequency is just too low for this person to get any gains. It looks like most people didn't pick 2. And the reason 2 isn't a great choice is, again, because of the time is so short. 3 and 4 are looking like better choices. 3, we're working at a pretty high intensity for the high, if you're doing high intensity interval training, this is an appropriate level to work. You're only doing it 2 or 3 times a week, which is appropriate for high intensity training and for doing it for more than 35 minutes. It doesn't mean you're working this hard for 35 minutes, but when you're doing your intervals, they are that hard. And then you either come back and rest, maybe you're walking fast, back to walking slow, or maybe you're walking fast and then actually stopping. So this is a pretty good program actually here, 3. You could argue about 4, saying, gosh, I would start a little bit lower on the intensity with someone with heart failure. That would be okay. The time would be okay. The thing that's pretty high though, is you really don't need to exercise 5 to 7 times a week if you're doing high intensity training. You really only need to do it a couple of times a week. But if you start off at this here, and if you told me the time they were doing was a lot lower, then maybe it would be a little bit better. But I would argue that 3 is your best answer to meet the parameters of high intensity interval training. All right. So I just wanted to show you again, this is the reference for a lot of the guidelines here for management of patients with heart failure. On the NPTE, if you have a question like the one we were just looking at, look at each component of the question and try to figure out what the optimal piece would be. Because like, especially for an exercise prescription, you have 4 components that we're talking about. You have the frequency, the intensity, the type, and the time, all the 4 components of fit. And you want to make sure all of those are within a range that would be beneficial. So in the last one we were just talking about, for things that are high intensity, you really only need to exercise vigorously 3 times a week for it to be beneficial. So I really push you to look at all the different components and break them down and see which one fits the guidelines that you know are to be true. Because those are really tricky questions, because usually only one part of it will be modified. So sort of look at it as like a mini true false and be like, oh, this time frame is too short. This is okay, this is okay, this is okay. So that's how I would sort of tackle those. All right. Well, thank you for a great interactive session today. If you have any questions, other questions, please let me know. Otherwise, I wish you the best of luck on your exam.
Thank you so much. That was a very interesting lecture. Thank you.
You're welcome.